Visual hallucinations. Letter of referral. Dear Dr. Re. Mrs. Christina Churchill, aged 63 years. I would be grateful for your opinion regarding this woman who has begun to experience visual hallucinations over the last 2 months. She has a history of depression in the past and takes amitriptyline 100 mg on, which she has done for many years, but is otherwise well. Physical examination is unremarkable. Yours sincerely. Introduction. There are many causes of visual hallucinations, which can usefully be classified as working classification of visual hallucinations. Perceived by the patient as real. 1. Psychiatric disorders. 2. Dementia. 3. Parkinson's disease, usually associated with anti-Parkinsonian drugs. 4. Acute confusional states, occur in addition to systemic features. 5. Delirium tremens, typically small moving objects or animals. 6. Some epileptic phenomena. 7. Drugs. Recognized as unreal by the patient, pseudo-hallucinations. 1. Purely visual. 2. Visual hallucinations secondary to eye disease, occurring in the whole visual field and disappearing with eye closure. 3. Causes may be simple or complex: cataracts, macular degeneration, glaucoma, choroidal neovascularization. 4. Hemianopic hallucinations, i.e. occipital lobe lesions, infarct, hemorrhage, or tumor, causing unilateral, usually complex, visual hallucinations, which disappear with saccadic eye movements. 5. May involve hallucinations in other sensory modalities. 6. Associated with epileptic aura or seizures, stereotyped and usually short-lived, 30 seconds, may be simple or complex, occurring in a hemifield and not affected by saccadic eye movements. May be perceived as real by some patients. 7. Associated with migraine aura, usually simple images, lines, fortification spectra, and flashing lights. 8. Peduncular hallucinosis, a rare syndrome of often complex visual hallucinations, sleep disturbance, and agitation that is secondary to a lesion in the midbrain or thalamus. 9. Drugs. Some cases present in the context of identifiable pre-existing disease, e.g. dementia, Parkinson's disease, or diffuse Lewy body disease, psychoses and migraine, but in those occurring de novo you must decide which patients are likely to have an intracranial structural lesion. History of the presenting problem. Keep the working classification shown in Table 11 in mind as you establish the features of the hallucination. Does the patient think it is real or not? What form does it take, simple or complex? Does it affect the whole visual field or just a hemifield? Is it affected by closing or moving the eye? How long does it last? If the patient has experienced more than one, are they always the same? Are any other senses involved? A full drug history is essential, including prescribed and non-prescribed drugs, as is a careful history of alcohol consumption. NB. Medication for Parkinson's disease is particularly likely to induce visual hallucinations. Other relevant history. Is the patient known to have a history of any of the following: stroke, Parkinson's disease, dementia, psychiatric disease, visual disturbance, epilepsy, alcohol abuse, drug abuse? Plan for investigation and management. You should begin by explaining that under normal circumstances you need to confirm that her neurological examination is normal. NB. Any patient with complex visual hallucinations in the absence of a known neurological disease, Parkinson's disease, dementia, delirium tremens or acute confusional state, should have a brain scan. Investigations. In addition, simple visual hallucinations that are stereotyped may well be ictal, and patients with these should also be scanned. The following may also be appropriate: screening tests, FBC, electrolytes, renal and liver function tests, including gamma-glutamyl transpeptidase, glucose, inflammatory markers, and CXR. Electroencephalogram only if frequent suspected ictal events. Management. This will depend on the diagnosis. Epileptic visual hallucinations usually respond to antiepileptics. Occipital lobe lesions. The hallucinations are often self-limiting and the outcome will depend on the nature of the lesion, e.g. stroke or tumor. Parkinson's disease. Reduce anticholinergic therapy and then dopamine agonists if the patient is disturbed by the hallucinations. You may need to reduce the dose of levodopa, but unfortunately patients do not tolerate this well. Delirium tremens. This is an unlikely diagnosis in a patient who is not acutely unwell. Further discussion. How would examination help distinguish the cause of the hallucinations? Visual system. The presence of severely impaired visual acuity may be the cause. Visual field defects will be extremely useful in alerting you to the presence of a space-occupying lesion and its likely location. Other neurological signs, particularly brainstem signs, peduncular hallucinosis, or evidence of Parkinson's disease, will also direct towards a particular cause.